Society, and especially the members who are coming from China, our industry and scientific partners from China. So enjoy the meeting, take the opportunity to also use the hands-on sessions, the lunch symposiums, and also take the opportunity to visit the Acropolis today with us, today evening. It is really a momentum which you're gonna never forget. I would like to ask Sabine Bleifeld-Ziffer from Germany to give us some highlights of the program. She created, together with Antonis Pitzis, the cardiac program. And this year we had also an innovation in terms of involving also younger residents and younger fellows who created also their own very nice program. So welcome, Sabine.
Thank you so much. It was a great honor to be involved in the program conception or in the, as a program chair. Just want to make clear that I'm not a young fellow, but others are. So we wanted to increase the educational level of the program, and therefore the cardiac expert sessions were completely restructured. First of all, we included in the program, as you can read and see, the objectives of each session, so you can know what you can expect and what you can learn in a session. And then all sessions are divided in two parts. The first is a more general talks about the respective topic, and is called the 360-degree view. And the second part, which is more specialized, includes more specialized topics, is called the deep dive. And all talks are case-based. So all education we want to have is based on experience of our experts and based on cases and a lot of video material. So I hope I didn't, oh yes, we also have live cases, which is new for the ISMICS. There are two live cases today, one in the aortic session and one in the mitral session. So thank you. I hope everybody enjoys this new concept of the program, and have a nice ISMICS. Thank you.
Okay, I am just we are ready to connect with for the OR. So okay, so we start the session. I am in connection with Dr. Pitzis. He is ready in the OR in clamping the aorta, and simultaneously he will present
Francis from ASM, I think.
Τράβαμε λίγο πίσω. Το ράμα. Έχει τη λούπη.
Eusanio, 840. Yes. That's me.
Like it's listed in the program, so.
This was trans-cervical. If you want to talk about trans-cervical.
Yes, that's my
Perfect.
presentation. So, the button, right. In our cardiac surgery department, we do perform aortic interventions using all available surgical intracatheter approaches. And when we focus on the surgical program, about 85% of valves are done minimally invasive and 15% with full sternotomy with some special indication. When we zoom in with minimal invasive approach, I must say that mini sternotomy continue to represent the most common approach, accounting for about 50 to 60%. It's very often associated with minimal invasive extracorporeal circulation. I would say that ERAS protocol are used in more than 90% of patients. We do perform, of course, anterior mini tracheotomies and transaxillary approach. These are most classic indications for sternum sparing operation. But I must say that over the last 2 years, we have basically abandoned the right anterior mini tracheotomy in favor of the transaxillary approach, basically because this is associated, at least in our hands, with a better valve exposition. That has a lot to do with the fact that intercostal space laterally is much wider, the soft tissue is much softer, and when you select well your patients, you get a very nice perpendicular trajectory to the valve, which makes direct view working very easy. So this results in our hands in an easier and faster operation, and then I think that cosmetically speaking, this approach is just unsurpassable. Invisible scar, this patient looks like a TAVI patient, not like a surgical patient from the front view. So I was asked to show a case. This was a patient that we operated a few weeks ago, relatively young, 68, but pretty sick. Severe aortic stenosis, ejection fraction of 50%. He had a liver transplantation a few years early. HB was less than 10%, renal insufficiency, and he was looking much older than he was actually. And this is how we place the patient on the table with the right arm up. That's good to widen even more the intercostal space. Serratus block or some kind of blocks are always performed. 100% of cases in our institution, we cut down for the groin vessels cannulation. Then we move to the chest. I can tell that the incision can be horizontal, let's say running over the axillary line. You don't need to make an oblique incision. This will result in a much more cosmetical result. In fact, when you divide the intercostal muscles, as we're doing it, you place your soft tissue retractor, your working incision will become oblique. And you see how nice is the intercostal space at the lateral level. This is the pericardium opening. We do it on the top of the aorta. It must be really high, very distant from the phrenic nerve, as we're going to place some stay switches on the pericardium that we're tying firmly on the skin because we want to bring the valve out of our incision. We work in direct view here. So we place 3 stay stitches anteriorly, 4 pericardial stay stitches posteriorly. And you see the right atrium is almost touching the chest wall. The pulmonary vein is at 4 centimeters from the skin. As Antonis has done, of course, when you're doing an aortic valve replacement, you need aorta, you need length. So we have to place our aortic clamp above the pulmonary artery, and we can dissect it very easily with the cautery, with the scissors, and I always like to check I have full control of the aorta before continuing the operation. Now I'm sure that I've got all the aorta I need, so I proceed with the left vent line placement, and it's there. When you look at these images, please always focus on the fact that I am close, I am perpendicular, and my eyes are always in the middle of my hands. So eyes and alignment is just perfect. The aorta is there. So we stop the flow, we pull back a little bit the aorta to gain some aorta, we place the clamp. This is a single incision operation. We open the aorta, as I do with first anatomy, so this is a OKJ stick incision. We place 3 phase switches, one on the upper edge of the atherectomy, the other 2 are on the lower edge of the atherectomy. In this case, I'm passing this switch transthoracic, and we should get the valve in a second. There it is. It's close, I am perpendicular, I see the 3 sinus entirely, and I can work with, even sometimes with normal instruments, and resect the aortic valve. This is the right coronary sinus, this is, and also imagine that I'm not, this is an HD camera, I'm looking at this with my eyes. The valve is resected as usual, and in this case, we're not depending on sutureless rapid deployment. We can either place sutured or rapid deployment valves. In this case, we decided to implant a rapid deployment valve, so we're going with 3 nadir stitches. I was not very correct in this one, so I'm using that as a traction, as a, yes, as a stay suture, let's say, to put a better one, which is this one. I removed the former one. And then you see how nice is a 4 centimeter incision laterally. The intercostal space, if you make an incision of 4, you get a field of 7 per 7. And this is the intuitive valve that we are implanting. Parachuting down. The tourniquet are seated. The balloon is inflated, the valve deployed, the holder is removed. We check the deployment has been correctly performed. We tie the 3 sutures, and then after that, I could tie this with my fingers. We close the aorta. You can make the proportion. You see that the deep of my field is only 5 centimeters or 6. You can understand that looking at the instruments that are going through the chest. The arthrotomy is done. Pacemaker wires on the anterior surface of the right ventricle. This will be passed through the chest. The airing clamp removed, as usual. We check for the arthrotomy, no bleeding apparently. And this is the final result. The patient was extubated on table, as we do in more than 80–85% of cases now. And these were operative data: 41 minutes clamp time, 72 minutes CPB time, 2 hours, and something more operative time. Patient was extubated on table, drains were removed the day after, discharge from the ICU after 18 hours, home discharge after 7 days. Transaxillary has been for me a really game changer, especially on the mitral, but also on the aortic valve. It is associated with the unsurpassable cosmetics, excellent aortic valve exposition, and compared to anterior thoracotomy, it's easier, faster, and nicer, at least in my hands. Thank you very much for your attention.
Yeah, thank you very much. A very nice presentation. So when you use the intuitive valve, these 3 sutures, you tie them at the end?
Yeah.
Okay.
Yeah, I always do it. Yeah.
Is it just to be on the safe side, or?
I think it's a standard technique for
Okay.
intuitive. I always do it.
And the other question is, do you use percutaneous cannulation also in some of your cases?
But I must say that we could do that because we're doing TAVR ourselves, so we have full control of all possible closure device systems. And but I'm a little bit reluctant because this is probably has to do something with logic. You need a CT scan for sure if you're doing percutaneous, because you want to know where the bifurcation is and how the bifurcation looks like, calcification, stuff like that. So we cannot scan all our patients. Sometimes when doing TAVR, we see some little complication that we have to manage with the fluoroscopy as well.
Mm-hmm.
You know, so we could do it, but still elaborating, let's say. It's 1 centimeter, we get 1 seroma per year, 1, maybe 2.
Yeah, okay. Other questions from the, here.
Hello, nice presentation, sir. I'm Dr. Lalit Malik from India. Sir, my question is, for every case, you go for transaxillary, or you make some pre-alpha angle for CT if aorta is straight.
We selecting patients for transaxillary AVR with a CT scan. That was the question.
Yeah.
How you look at the CT scan, and from the coronal view, we can have hundreds of information, and some of the most important ones are the distance from the valve to the chest wall, also the angulation. So horizontal aorta will fit better because they will look forward the armpit, let's say, and then we basically measure the distance to the valve and the angulation, basically. But then on the CT scan, you can have information to select your patient's small roots, calcification, the width of the intercostal space. So there are so many information you can get there.
So this depends upon CT, not for every patient for this transaxillary.
We selecting our patient with the CT scan, basically less and less, but we still do it. I like to be very clear. This is more difficult than mini sternotomy AVR, for sure.
Yeah, thank you.
Okay, we have one more short question before we have to go back to the operating room.
Mark Bell from Ottawa. I think this is great. I think it's a bit unfortunate that we don't have a lot of single AVRs coming to us anymore. So right anterior thoracotomy works pretty well. It's just it seems that the numbers keep going down. That's certainly my go-to operation. You can do anything. You can do mechanical, you can do a root enlargement, you can do manugan. I wanted to ask you a question about cross-clamping. Definitely with those operations, one of the disasters is if you open and your cross-clamp is not through, right? So I like to put an umbilical tape behind the clamp, and the other thing that I do is I check with echo. After I've given my initial antegrade pledge, I stop and I make sure that the aorta is silent. The ascending aorta is silent, so there's no leak through our clamp. Is that something you found useful as well? Thank you for a great presentation.
Thank you for your question. For sure, you must be sure that your aorta is nicely clamped. And as I said, I like to prepare the posterior wall of the aorta and dissect it from the pulmonary artery, and I check that my jaw is going the other way to the other side. When I'm sure, then I clamp and I give cardioplegia. That's it.
Okay, I think we go back to the operating room.
Thank you.
Matthias?
Okay, so it is time for me to change gloves because
Houston, Texas, United States of America, is going to give us his presentation.
Thank you for the opportunity to present our experience with robotic AVR. Let's see. Slides doesn't move forward. Trying. There we go. I think you've seen a lot of ways to do an aortic valve. What's really important is we're truly innovating, and I'm really glad to be part of this meeting. That's where I've seen how to do an AVR other than through a sternotomy approach. But we just need to do something not just to be different, not that the incision is small, but we need to add value. And I think what you've seen with these procedures, adding value, you're avoiding rib spreading, you're avoiding a sternotomy, and I think that's what we need to strive for. So we're continually evolving, trying to produce not just a better cosmetic procedure, but a better overall experience for the patients. And we're going to describe our experience with the robotic approach. The first case will use a sutureless valve, the Percival valve. We do femoral cannulation. We do percutaneous femoral cannulation in all of our cases. We don't use a PA vent. We don't use a coronary sinus catheter. In our cases, we use LV vent sparingly. We do not rib spread. We don't shingle a rib. It's all as minimally invasive as possible with this approach for sake of time. So this is the approach. I showed this video not to see how to make an incision, but the true reality, this is how big the incision is. It's there, it's sized by charging the extra large Percival sizer. I mark it, and it has to be that big because I can't get the sizer in. Even that, it's hard to get the sizer in. And that's our limiting factor in terms of being completely total endoscopic with ports. Our approach, second interspace, ideally is for the Percival valve. Can you do a sutural valve through a second interspace? Yes. Third interspace or fourth interspace for AVR or concomitant with maze, or double valve, ideally is a fourth interspace if you're going to do a mitral valve concomitant. This is the double extra small, and that's the size of the Alexis we use for this case. Hopefully we could get smaller once we get better sizers for the Percival valve. In terms of our arms, first interspace, arm 1, our working port is arm 2. The cross clamp goes either in the first or second interspace. We've moved to putting the cross clamp in the second interspace as posterior as possible to be able to get out of the way. You could use a detached clamp, which also eliminates interference with your arm. As I said, peripheral cannulation in all cases. Large pericardial window. For time, you don't need to see me do a pericardial window, so I'll skip this video. Cross clamp, have you seen with every video, we go above the pulmonary artery. We try to get the exposure as high as possible to be able to place this cross clamp high to get it out of the way of the instruments, especially the robotic instruments. We try to make sure we don't get into the PA, so we do this all direct vision. In terms of cardioplegia, we just stick it in and give it and then take it out and use that site as our aortotomy site. We could also place suture if you prefer it to be guided. That can be done. For sake of time, you just guide it through and it sticks. We use the actual holes on the cannula, so you know exactly where it's going to go. We're taking it out, so it's not a big deal that you're doing that. It's not staying in. We take it out. We use the exact same site for our aortotomy. So this is the case. Standard transverse aortotomy. In most cases, we could actually extend down if you want to do a root enlargement. You could do that. You can extend down towards the non. If you're worried about the angle for aorta tearing, you could also extend it down the non-sinus. The scissors are pretty strong. It can do the job. The rest can be, you could use the Eusanio, which I use as a rongeur, has a tight enough grip to debride calcium. You could still use the MySonics to do so. We place our 3 major sutures. We use foro C1 sutures. You can use foro RB2s as well, or RB1s to perform this procedure for the Percival. So we could use the scissors for decalcification, the Eusanio, rongeurs from your bedside assistant can use it. You could use the CUSA, the MySonic, Sonopet. You could use everything that as you do in an open case, in the robotic case. Sizing is difficult. So this is one of our first cases. So you could see that the sizer went in very easily because the incision was large. This was a 5-centimeter incision when we first did this. So now the sizer has to be bent and then re-bent back by the robot inside the patient. And we size as normal. This is, of course, the size is too large until we get the size we want. And for sake of time, you don't need to see me keep sizing. The valve comes in. As you can see, there's definitely space here. On the newer approach, there's no space. We don't have a shot of it because the valve goes in first, then we bring the camera. There's no space to put both at the same time. And then we examine the valve as we would in an open case, make sure that we're seating on the annulus, and we look in the valve with the camera. This case had an LV vent. You don't have to use it in every case. If you don't like a spot, fix it. I don't like figuring out paravalvular leak post-op. I like to figure out pre-op. That's a paravalvular leak right in that corner. So we move the valve. The company, please, hopefully you're not looking because they hate when I do this, but you could actually place it above the annulus and you're done, instead of having to take the whole thing out. Closure, that is, let me see if I could run this. It's the only part of the video I have in real time, on purpose. You will not make up time on your aortotomy closure, especially in the beginning. It takes time to close the aorta. So redose if the case is going a little bit longer, because this is going to take time. This is the standard aortotomy closure with a horizontal mattress first and then an over and over. So I don't do this approach all the time. If the aorta is a little bit large, I do it. If not, I do a single over and over, and I leave the two ends to rerun it if it bleeds once the clamp is off. Usually a single over and over is enough to do the case. I use the MANTA system for percutaneous closure of the artery. I use it on the vein now. Previously, I used to use ProGlide for the vein. Of course, you could do a cut down or any approach that works. So total, this is, Sam, this is one of your pictures, so I stole it. I put it here. So this is how small you could get. All right, this is how we've started our approach with a 3 centimeter incision, but you could get smaller. So it's doable, totally non-rib spreading approach. How about, well, what if you size out? For sake of time, I'm going to pass it, but you've seen this part. You could put a regular valve through a second interspace. So if you size out, you're not stuck to convert. You could keep going. This is a second interspace anterior thoracotomy robotic approach for a sutured valve. This is an EPIC Max valve that's being placed, and it can be done with a sutured valve. Of course, we use core knot in every case. So this approach lends itself to if you size out, to continue with this approach to do so. The incision is larger. You have to be able to put the sizer and the valve through. It's a little bit larger, but it's doable even if you size out. And of course, it's a team approach. You got to simulate, you got to work hard with your team to be able to get there, but it's doable. And I think that the biggest benefit is not a RAVR, it's a TEVR, so it's a totally endoscopic AVR. I borrowed this term from Sam. So here we are, and thank you.
Thank you very much, Dr. Ramzy. That was a really impressive presentation. Well, I can ask you, this procedure looked very similar to what we see now in a live case. What is the really advantage of doing it robotically?
So the advantage of the robot, you could become totally, especially with the Percival, you could be basically, once we have a better sizers, you're totally endoscopic. It's just ports. Yeah. There will be only ports, and that I think is where we're striving for. Now, if you're looking for a totally endoscopic approach, whether it's VATS versus robot, if you're doing a sutured valve, the difference is, I think, with a robot, you're a better surgeon. You have your wrist, whereas VATS is a harder procedure. If I do a VATS procedure compared to a robot procedure is easier once you're past that learning curve. But you have 7 degrees of freedom versus 2. So I think that is the main advantage of the robot when you're talking about a fully sutured valve.
Yeah, of course, a little word of caution using a Percival valve, because where do we in future put those valves in? It's young patients, bicuspid patients. You want to have a long-lasting valve. I personally would be a little bit restrictive in putting a Percival valve in a very young patient. So you need a little bigger incision, obviously, to put the modern valves in.
No, that is very true. That's why I put that video at the end of me putting an EPIC Max, so the approach is doable for all kinds of aortic valve. I've used it for Inspiris, I haven't put an Evalis, but once it's on the shelf, I'll put one. I will use every valve just to show that the platform is not limited to a certain type of valve, so that any surgeon who wants to be able to do an aortic valve, they don't have to change the valve they use. They just could continue with their normal practice. But I think the robotic platform basically enhances the surgeon's ability to do the case easier.
Thank you.
Nice presentation. Obviously, comment on Perceval. We have even since 3-4 years now the Perceval Plus, which also has an antiphospholipidic treatment. So we will surely probably expect also good results in terms of durability. And robotic is an innovation and not an invention. Listen, Antonius wants to show us how he is closing the aorta live.
Sorry,
Antonio, can we come back to you?
Can I ask one question?
Please.
Yeah, we
Okay.
So,
Okay. Until now, we already saw the 3 different technology for the aortic valve replacement. I never done the robotic aortic valve replacement. I just try the endoscopic and the directly vision. Yeah, and so this morning we
Can you put a short question? Short question.
Okay.
Yeah.
The question. So what's your opinion for the young surgeon to start the minimally invasive aortic valve replacement? I don't know. Now I give up the endoscopic because I prefer the directly vision because it's faster. So what's your opinion? Thank you.
So I think my main message is to have the minimally invasive mindset is the first thing, is to not be stuck in we do it sternotomy and we always do it this way. I think a minimally invasive approach that works for you is the key. I think you saw several different approaches. I think they're all minimally invasive. You find one that works for you, and then you evolve from there. I did not start robotic AVR. I started with a right anterior thoracotomy that was 7.5 centimeter. I know it's 7.5 centimeter because it was the size of a small Alexis. And then I kept getting it smaller, and then using VATS, and then I moved on to the robotic platform because I was familiar with the robot on the robotic platform. So you find the approach that gives you reproducible, safe, good results, and you evolve from there. You don't start with what you're seeing in the video here today from your first case. You have to be familiar with the basics first, and then evolve from there.
Okay. Thank you.
Okay. Thank you.
Okay. Thank you.
I think the next is a video presentation from Tom Holubec in Frankfurt. Maybe we can start that. Can you start the video? Okay, it's running, but we don't hear anything yet.
ISMICS program and organizing committee for this kind invitation. Unfortunately, I'm not able to be in Athens in person, so I hope you will at least enjoy my pre-recorded presentation. These are my disclosures. Let's have a look on the challenges of the minimally invasive aortic root and arch surgery. So, of course, the access to decide a J-cut, T-cut, to the right, to the left, which intercostal space, cannulation, root valve exposure, of course. If you have a lot of these nice drawings, you will see the relationship of aorta to sternum. And this is very important in planning the surgery. So you can see if you have the aorta right to the left or right to the right. So both can be challenging for this kind of surgery, as well as in especially elderly patients, like on this drawing. You have kind of the census of the heart pulling the aorta artery down. This case, like this one, can be also very challenging via meniscectomy. In this kind of surgery, we perform preoperative CT scan in every patient. You can have a look, of course, beside the axial views also to the sagittal, and as a kind of very simple tool how to get some idea about the anatomy, how deep is the aortic root. If you just scroll the pictures and put your cursor, and then you go just from the aorta against the intercostal space, so you can get some tells about the anatomy. You can even go a bit more further and use some more sophisticated post-processing after CT scan. We use Trimengine in our department, and if you have a look on the left-hand side pictures, you can really see how nicely you can play with these pictures, going really from the skin of the patient really deep to the mediastinum to get some ideas how is the anatomy, or on the right-hand side to get some more ideas about the aortic root, the cuspidity of the valve, the sinus portion, and some measurements.
Now let's have a look on the setting of mixed aortic root surgery. In every patient, we use a percutaneous cannulation of right femoral vein. As you can see on the video, puncture of the vein and placing a guide wire, important under TOE control, and the tip goes right to superior caval vein. Then it's followed by skin incision 6 to 9 centimeters and performing upper meniscectomy using a standard stitch saw, in this case going into the right intercostal space. Afterwards, placing of a long venous HLS, getting a cannula, as you can see here, without any dilation. It goes smoothly in because there is a long graduated tip. After placing of 2/4/0 purse string sutures on the proximal aortic arch, we go for Seldinger cannulation, arterial cannulation using again HLS cannula.
Here's just a quick accomplishment of the previous slide and video. Because for mixed arch surgery, we use standardly axillary artery cannulation, and then very frequently we debranch intrathoracically the left subclavian artery, and then we go for so-called trilateral antegrade cerebral perfusion. Otherwise, the setting is more or less the same.
Here you can appreciate a minimally invasive aortic valve and aortic root replacement. We use a self-assembled valve graft based then sizing on standard tissue valve sizing. In this case, Edwards Inspire is 27 millimeters. If you add 5 millimeters, you end up at 32 millimeters cardio root graft. So this is a nice trick. So if you crimp up the last or proximal 5 millimeters of the graft, then you can suture easily the tissue valve using a running 5/0 suture, and it allows you, if you need to reoperate this patient later, just to remove the suture and the tissue valve easily for any replacement. Then we suture down the graft using interrupted, braided, pleated mattress sutures, and in the sake of the time, I will move further. I brought you a aortic valve reimplantation in minimal invasive sexes, so exposing of the valve. So you can see here that then a sizing, and you can again here see, so the root is just fitting into the excess, about 6 centimeters, skin incision, sizing using Hagar dilators, and this is a Curie sizing, so you saw 30 millimeters, then we choose a 30 millimeters cardio root graft. Dissection of aortic root is very important, especially between aorta and pulmonary artery. Then we go for, in tricuspid valve, 9 pledgeted braided 2O sutures, put it from LVOT to outside, and here you can already appreciate the partially reimplanted aortic valve showing a very good effectified using a Schaefer's caliper and good coaptation. And we follow the procedure by accomplishing the distal anastomosis using a 5O running suture, and again a water test showing a great coaptation of the valve. Similar in a bicuspid aortic valve, 3 sinuses fused between the left and right cusp. As you can see here, there was a thickened and calcified raphe which has been resected and resutured, and then we actually give 480 degrees orientation of the commissures, and then we've accomplished the procedure in standard way, putting a sutures from LVOT to outside, and then put this valve after sizing into 32 millimeters Dacron graph, again cardio root. You can see a nicely partially reimplanted valve showing no prolapse, good coaptation.
Finally here, I would like to show you a minimally invasive complex aortic arch repair using a trifurcated hybrid prosthesis in frozen elephant trunk technique. We used this prosthesis since a couple of years because of its features and suitability for especially minimally invasive surgery. Basically, before going to cardiac arrest and circulatory arrest, we branch the left subclavian artery intrathoracically, suture and graft on it, and put a perfusion from artery line. Then in circulatory arrest, you can see implantation of the new Evita Open Neo with its new device. It's very intuitive and user-friendly. Currently on the so-called trilateral antegrade cerebral perfusion, then following with the collar anastomosis, and it's important in zone 0. So this is very suitable for proximalization of the anastomosis. We use a 3O running suture with Teflon felt strip that we cannulate an anteflow graft and start the distal body perfusion. And then the surgery is accomplished by consecutive anastomosis of left carotid common artery to the second graft, and the brachiocephalic trunk to the first graft. So you can see here the accomplished surgery after hemostatic phase. Let me summarize my talk. The dissemination and adoption of MICS, especially mitral valve repair, aortic valve replacement, is based on clear benefit and evidence. However, minimally invasive complex aortic root and arch surgery, like valve-sparing aortic root replacement, complex aortic arch repair in fat, there is a low and little evidence, however feasible and safe. And there is a clear benefit not only because of cosmesis. So I would conclude the surgery is for every patient and pathology, however precise selection and pre-operative planning, especially CT angiography of patients and centralization to experience centers and MICS are warranted. Thank you very much for your attention.
Yeah, we can unfortunately not have a Tom here for a discussion, but it was a very nice presentation on showing the real value of your upper sternotomy, not for isolated aortic valve replacement. We've seen better approaches for that, but for complex surgery, aortic root or aortic arch, I think this is still an excellent technique. Matteo.
I totally agree with you, and you can really do with a mini sternotomy a lot of aortic surgery, so that's true. Antonius is declamping the aorta and is calling us back. Can we connect to the OR? Antonius, we are...